heading back in for another day at Stanford Hospital for some therapy work with Rita. We've been doing therapy work for about 6 years. We're going on our 7th year. Okay, let's get Euan back. Come. Rita, let's go up. Before every visit, the dogs have to go through a complete grooming to make sure that they are as antiseptic and clean as possible for all of the patient visits. Okay, it's your paw. Another paw. There you go. Okay, let's go.
We definitely see our program as part of the healing process in a variety of ways. Be it on the physical side or be it on the emotional or mental side, we really see ourselves as a part of the healthcare team and a part of what the uniqueness of what Stanford brings to our patients.
Surest thing for getting the dog to do her potty break before we head in is mother of all fire hydrants here in front of the hospital. Good dog, Rita.
If you ever noticed any of our teams walking down the hall, going towards a unit to see a patient, they are stopped left and right by visitors, by employees, by random people walking around, very happy to see a dog in a hospital.
It's a genuine therapy. It's a heart-to-heart, immediate connection. There's nothing in the way. It's just instant.
Ready?
There we go, what a good girl.
Okay,
how
so
funny, how pretty.
we're okay. Rita likes that body contact, so let me know if there's any pressure too much. We'll just reposition her.
I'm fine.
What I've seen happen between patients and dogs when we bring the pet in to visit is it's quite enormous, actually. There's a lot that goes on.
So good girl.
Yeah.
Hi, Rita.
I'll say who I am. I'm Nan with PAWS at Stanford. What does that mean? I'll go like this, Pet Assisted Wellness at Stanford. Oh, I have a dog. That's how it'll start. There's an exchange that takes place immediately, as if the magic starts.
She's on her back with the
There's nothing like a dog. I don't like people. I like animals.
a lot easier to figure out for the most part.
It alleviates pain, it alleviates high stress, it alleviates anxiety, which are very common traits in a hospital. In this environment where people really don't want to be, no one ever says, hey, let's take a vacation to the hospital. We in guest services try our best to better the patient experience, both for the family and for our guests.
When I walk into a room with the pet, I have seen the patient's demeanor. I walked into a man's room and he was very disgruntled. I told him who I was and he goes, a dog? What do you mean, a dog? I said, well, you're here in the hospital and this dog is here for you today. Would you be willing? Would you give it a try? So then he sees the dog and he goes, oh, hi, little Poochie. Oh, come here, come here, come here. Come on, get up on the bed, get up on the bed. He saw this softness come on his face, and then he started to cry. And he was a big man, kind of with a guard up and everything. Well, 2-3 days later, he was still in the hospital, and I saw him trucking down the hallway. He saw me, and he said, hey, I know you. You're the PAWS lady. Some people actually call me Mrs. PAWS. And he said, after that visit, I had hope again. And he said, I told my wife, and she said, I wish my wife could have come and given you a kiss, because she said, I've never seen him smile like that.
Good dog. Okay.
When people are talking about women's heart health, they're generally talking about the whole cardiovascular system. And so one thing that we know about cardiovascular disease in general is that it's quite common in women. And since 1984, it has been more common cause of death in women than men, actually. And that has been rising over time, whereas men's cardiovascular deaths have been decreasing over time. In terms of heart disease, women will have chest pain just like men. So we talk about the fact that women are different than men, and certainly they can be, but chest pain is going to be the most common symptom still, and so women should not ignore chest pain if they have it. The prevention advice I don't think has changed over the last 50 some years, but good old-fashioned diet and exercise is what it comes down to. But in addition, you need to know all of your risk factors, and there are a whole host of them. So a woman needs to know what her blood pressure is. She needs to know her cholesterol, her good and bad cholesterol, her triglyceride level. She needs to know how her sugars are running. Having excess weight and not exercising regularly are other risk factors. Maintaining a normal weight or getting to a normal weight if you're not at one. This is important for younger women to start early in hopes of maintaining, because once you're down by 20 or 40 pounds, it's a lot harder to lose it. And then just eating a healthy diet, and I think most people actually know what a healthy diet is, but they don't always follow it. The whole basis of our center is to take things that we know that are unique about women and identify those things or apply that information. There's been a decade now of research on how women are different from men. So we're really trying to use that knowledge that we have to make sure that we identify women correctly if they're having a heart problem, do the right tests on them to make sure that we get the right diagnosis. We also have a support group here for women that have been diagnosed with heart disease or had heart attacks or had bypass surgery just because of the emotional stress that goes along with all of this and how that affects how they feel. That's an important part of their overall care. So it's not simply the medicines and diet and exercise, but also addressing that stress component. I think the biggest thing that we need to do is eventually just start naturally treating women like women, as opposed to having to have special centers like we have now where they have to come, and we're thinking about them that way, and hopefully their doctors and cardiologists will always think about them a little bit differently when they come in, you know, once the information is well disseminated. But I think we have a few years until that time.
I've always struggled with weight. I think that I invested a lot of time and energy into the battle with food. I hadn't realized even how much space it took up. And probably connected to that was a deep fear of dying young. I was a cardiac incident waiting to happen. Having kind of put on weight as an adult, I was probably carrying around an extra 80, 90, 100 pounds. Throughout my 30s, you know, it would be uncomfortable and I'd go up and down, but it began to manifest itself with health issues, high cholesterol. I was diagnosed with diabetes, hypertension, and had all of those risk factors. You know, I couldn't have imagined that it would play out with a cardiac event, but 2002, I'm in the pool with my son and start getting chest pains, and lo and behold, I had a minor heart attack. My cardiologist said, you know, I really think that you need to think about gastric bypass in order to help you with overall health. And I resisted it. You know, I really thought I can do this on my own. I'm motivated, I'm educated. And so the more I kind of struggled, and the more I realized I might not be able to do this with my own willpower and desire and even psychological support. One of the doctors who belongs to the center said, go talk to Dr. Morton.
I think bariatric surgery was a very good option for the rabbi for a variety of reasons. He had a lot of serious medical problems that weren't being adequately addressed with traditional medicine. He had high blood pressure, he had diabetes, he had sleep apnea, he had reflux disease. He was on about 11 different medicines. He had also suffered through many different cardiac ailments. He had had a heart attack, he had stents placed, so gastric bypass met his needs very well.
When we met, I actually remember leaving Stanford feeling relieved. I had kind of come to the point of nothing's working, and this is an option that really might give me the ability to succeed.
The way we look at bariatric surgery here at Stanford is it's just part of the puzzle. It's a tool to help the patient. And after surgery, you have to be able to use that tool. And one thing that we feel is very important after surgery is education. When patients come into the program, they get a lot of education. It's almost like a mini university, if you will, when it comes to weight loss and weight management.
I really went into the surgery with the mindset of this is going to be a catalyst in what's been a long process of truly healthy living. To have gone into this procedure and to emerge the day after with your diabetes is gone and you don't need medication, to have the blood pressure gone, to have all of those risk factors so severely reduced, that feels great.
If you think about it, what other operation or type of operation will give you one solution to about a dozen different problems? All those medical problems that he had before, the diabetes, the high blood pressure, the sleep apnea, the reflux, they all got better and actually went away, which is really remarkable, and it shows the powerful effect that gastric bypass surgery can have.
I feel wonderful on many levels. The degree of vitality and the degree of energy and the degree of, just kind of enthusiasm for the day is exciting. I feel like I have the pieces in place for longevity.
My name's Euan Ashley. I'm a cardiologist here at Stanford and I specialize in heart failure, which is a disease where the heart muscle doesn't pump as efficiently as it should. My friends are often asking me what they can do to keep their heart healthy. And so I tell them diet and exercise. And this doesn't need to be going to the gym, it doesn't need to be a gym membership. This can be walking. But do something every day. Do something for 30 minutes, get your heart rate up. It's good for your health, it's good for your heart, it's good for every organ system in the body. Basketball, of course, is one of the great American sports, and growing up in Scotland as I did not have the opportunity to play basketball. I grew up playing football or soccer, but I love the game of basketball. It's fast, it's furious. The idea of throwing the ball around the court is great, and it's a really social sport, so it's a chance to hang out with other friends and other cardiologists and try and keep ourselves healthy. The most important thing on a daily basis I think I do for my heart is to think about what I eat every time I eat. One of the things I often tell my patients is that if you're healthy on the inside, you're healthy on the outside. In particular, I'm known in my clinic as an expert on the heart and an expert in constipation. So start every day with a high fiber cereal. Have that with a banana in the morning and your day is off to an excellent start. My worst habit in thinking about heart healthiness is portion control. Everybody gets hungry, you have a long day at work, you head home and you're very hungry, and while you're starting to cook dinner, you start to eat, and you snack, and then by the time you're eating dinner you find you've already eaten enough calories for the whole dinner. My favourite food is unquestionably chocolate, but chocolate poses a problem for heart healthiness because you have to eat it in small portions. I think the fact that every day in clinic I see patients who have heart problems brings this home that the sort of behaviours that we have in everyday life can really affect how our heart functions, and the fact that decisions you make on an everyday basis can really affect how your heart is healthy, and how you live your life can affect how long you might live. As a cardiologist, I'm talking to people every day, trying to give them this advice, and I'm trying to live it every day, to keep my own heart healthy. Just go out and try it. It's not as hard as you think. A little bit of exercise every day, a little bit of organisation, think carefully about your portion size and what you eat, and that'll keep your heart healthy and happy.
Veins are part of the circulatory system. They return venous blood to the heart. Once venous blood gets to the extremities, it needs to be returned to the heart somehow to continue to circulate. Veins have valves. Venous disease generally develops when vein valves don't work properly. It can be as simple as a cosmetic issue where you have large or prominent unsightly veins. That can progress to, if the blood is static, meaning it's not moving, clots can develop in those veins. The most common form of venous disease would be varicose veins. That affects women disproportionately. Estimate is that by age 50, about 40% of women will have clinically significant varicose veins. More serious consequences of venous disease would include deep vein thrombosis or phlebitis. The problem with deep vein thrombosis up front is a life-threatening consequence of a clot breaking off in the leg, traveling to the lung, causing you to have trouble breathing or have your heart have trouble functioning. The treatment option for those include treating with blood thinner, which can be done either passively or more aggressively. We can use a catheter-directed procedure to actually actively remove those clots. Treatment options for varicose veins and more common vein disorders depend a little bit on the manifestation. Some people find that they have prolonged standing, they get leg swelling, pain, discomfort. That can be effectively treated just by wearing prescription-grade compression stockings. Traditionally, a more definitive long-term treatment would be stripping those veins out. That involves a variety of surgical exposures and usually a general anesthetic, perhaps up to 2 weeks recovery period after the procedure, but good long-term treatment and symptom relief from that. We can introduce a venous catheter into the vein that needs to be treated, advance under ultrasound guidance to the end of the vein, and then sequentially pull the catheter back through the vein, treating the vein from the inside out. It generally takes 30 minutes to an hour. Patients recover for 15-20 minutes in our recovery room. They get a ride home and they're back at work with no restrictions the next day. There are very specific and effective prevention measures, for example, to prevent deep vein thrombosis. That would include avoiding high-risk environments. For women, don't take birth control pills and smoke cigarettes at the same time. For people on long-haul plane flights, make sure you stay well hydrated, move your legs frequently, get up and walk around the plane whenever possible. Going forward, we have a number of interactions with local device and drug companies looking at combined drug and device strategies for vascular disorders, including venous problems. We have almost a universe of treatment options and specialists with a background in managing both the functional and cosmetic issues of venous disease, which we think can improve everyone's outcome.
I definitely play it off as not a big deal. I think most other people with CF do. It's just one of those things that I've gotten so used to that I don't think it's a big deal in my life, but I think I would want people to know just how hard it is. My name is Molly Pam. I'm a senior at Stanford right now. I was diagnosed with cystic fibrosis when I was 10 years old. I had no clue what in the world the word they had just told me. I don't think any 10-year-old could tell you what cystic fibrosis is unless they actually have it. All I knew was that I suddenly had an hour and a half's worth of medications to do in the morning. My parents were treating me different. My mom was crying all the time. That was the biggest difference, being told from everyone in my life that I was now different and not really understanding why.
Cystic fibrosis is essentially a genetic lung disease, and it affects a certain protein that patients are unable to regulate chloride or imbalances in their system. And as a result of that, we have disturbances, particularly in the lung system, which accumulates a lot of mucus that we can't get rid of. It also affects the pancreas, the liver, the reproductive system, the gut system, as well as the sinuses. So it's a multi-system problem that these patients tend to have.
In 6th grade, we had to do these disease reports for our biology class, and I chose to do mine on CF, and I knew everything, like sort of the conceptual, it's a fatal disease, all of that stuff. But it was really the first time that I had done my own research into it, and it really hit me just how serious it was. At that point, the median age of survival was still 28 years old. It's now up to 36 or 37. So hopefully as I get older, the age will keep going up. But that, I think, was really a shock when I was 12 to say, wow, I am almost halfway done with my life right now.
Since her diagnosis at Stanford at the age of 10, Molly has had a rocky course. In her early teens, she developed a significant inflammatory component of her lung. We had a couple of years of really having a deterioration of her lung. Over the last 5 years, which I've been caring for Molly, we've had some great stability in her lung disease. In fact, I think that it's been settled a little bit. It is very difficult to prognosticate on what her longevity will be. We hope that based on the literature she will live well into her 40s, possibly 50s. And as time goes on, these numbers may actually change if we have better development of therapies, and that's my hope.
One of the most important things that's happened to our program recently is we've been able to develop an adult cystic fibrosis clinic here at Stanford so that the adult patients, instead of having to be seen at the Packard facility, are now seen at Stanford, where we have our multidisciplinary team in place.
The blessing and the curse of being diagnosed late is I had a normal childhood. I was a very sickly normal child, but I didn't have to do meds. I knew what it was like to be treated as a normal person and not as someone with a fatal disease.
It's a big basket of medications that she does. Generally, what Molly will be doing is using an inhaled bronchodilator. And what the function of this does is basically to relax the airways. The other aerosolized solution she's doing is pulmozyme. And the function of the pulmozyme is to break down DNA and allows to clear the lung. The other therapy is inhaled hypertonic solution that comes into the lungs and basically helps to break down the mucus and also triggers a cough reflex and allows her to cough. Following that, she will do airway clearance. Molly uses the vest, and the vest basically pounds on the chest throughout. Now, the function of the vest is to kind of percuss or massage the lungs to allow the adherent mucus to release and enable her to cough this up. This routine will be continued 2 to 3 times a day. In addition to all of that, Molly has to do her exercise routine to also help with her airway clearance. And then lastly, there's a whole bag of medications that she takes.
This is going to sound really cliche, but they always talk about in CF, quality of life over quantity of life. And I will gladly trade a week going down the Grand Canyon for 3 weeks in the hospital, just to have that one amazing experience with my family. Just these once-in-a-lifetime opportunities, to me, are more important than doing my meds every single day, just living in the routine, trying to live as long as possible.
You can be happy and be happy every day and understand you have a disease beside you. Molly has mastered that, and she knows how to have a great quality of life. CF does not have to dominate your life in any way. It can slow it down a little bit because there are a lot more therapies that one needs to do. But if Molly's a prime example, you can have a disease, but you can also have the rest of your life in full form. So, that's something I commend her on every single time she comes in.
Chronic pain is extraordinarily common. It is affecting approximately 1 in 5 to 1 in 6 Americans, which means we're looking at anywhere from 50 million Americans or more who suffer on a daily basis from chronic pain. The sad thing about chronic pain is it affects everybody. It doesn't discriminate. It affects men, women, young, old. It does tend to increase in incidence with age, and so with our aging population, we are unfortunately going to be seeing even more people suffering from chronic pain. The most common reasons are conditions such as low back pain, neck pain, headaches, abdominal pain, pelvic pain. Back pain being probably one of the most common reasons patients go to see a doctor, only superseded by the common cold. We're beginning to think more and more of pain as a chronic disease in and of its own right, much like any other chronic disease that we have in society, much like diabetes, like heart disease, asthma. And if we think about those chronic conditions, we haven't cured a single one of them, but we've got great ways of managing them. We work very hard to first diagnose what's going on with the patient, and then to put together a treatment plan that's comprehensive in nature, that includes a large part of education to help them understand what's going on with their bodies, why they're experiencing pain, and what they need to do to ultimately move forward and to get better. I like to think of the treatment for chronic pain as involving 4 major categories of therapies. So we have pharmacologic treatment. This involves the medications. Interventional approaches. These are nerve blocks. These are anything from simple trigger point injections, epidural steroid injections, peripheral nerve blocks, all the way up to implantation of spinal cord stimulators, implantation of drug delivery systems. Again, these are more advanced techniques. Third, physical rehabilitative approaches, physical therapy and occupational therapy. It's crucially important that patients get re-engaged with their bodies, that they learn how to strengthen their bodies, increase endurance, that they have education about their bodies. Fourth, these are psychological and behavioral approaches. Approaches that many people often want to skip over because they feel that by acknowledging those approaches, that somehow the doc may be thinking that it's all in their head. And I work very hard to disabuse patients of that notion. The key to this is, and I think what is unique about our center and what's unique about other very comprehensive multidisciplinary centers, is the way that we bring it all together. And that is to bring it together in a team-oriented approach where all of these components are used together by people coming from different specialties and all working together in one location. And that's where we get the best results, and that's where the research shows that you will get the best results.
None of us really know what the technology environment will be like 10 years from now, 20, 30, 40, 50 years from now. But we all know the pace of change for technology is just accelerating. And we've got to design a hospital that's set up to adapt to whatever change that technology might bring. One of the hallmarks of the Silicon Valley is how companies work together to bring all of these incoming technologies together to create products or things that truly change people's lives. And the same thing's true at Stanford. Stanford's a leading university in interdisciplinary studies. Our ability to bring people from different fields together to solve some of the world's problems. The whole idea behind the Stanford Hospital Corporate Partners Program is to unite the pioneer companies of the Silicon Valley with the new Stanford Hospital to create methods of taking care of patients that really haven't been imagined yet.
One of the incredible things about being at Stanford and developing a new hospital here at Stanford is being part of the Silicon Valley. We are sitting around some of the most innovative companies in the history of the world. And so being here in the heart of this area, we truly can define a future unlike any place else. The facility that we're designing is taking the input of these great people, and we're thinking about what are the needs not only of today but of tomorrow.
This is a place where innovation is the name of the game. This hospital could have been a block like this tall, full of rooms, and that would be it, right? But the world around the patient is a complex world. The way to tap on them and to understand exactly what is it that they need is what is informing the basic organizational principles of the building.
The original Stanford Hospital that I'm standing in front of today was built during the Eisenhower era, over half a century ago. And that was the same time that many of the great companies we know today were just planting their seeds. Today, just as Stanford medicine has matured, these companies have matured. And I think they believe it's time that they can give back. And the impact will be profound for the local community throughout the Bay Area and eventually to the world as the breakthroughs in medical care and the breakthroughs in patient services that can happen at this new hospital are adopted worldwide. It's really a one-of-a-kind opportunity.
We are so thankful not only for their philanthropic support, but the support of their leadership as we define and develop and design our new facilities. And as we head into the next few years and the next decades, I think we can truly write the future.